There we go. Thank you. It'll be eventually. I'm just kidding. Good morning, everybody. Thank you so much for attending our Guiding Rounds, as we're restarting for 2020. My name is Jean Salcedo. I am one of the chief residents for ETSU Psychiatry, and I am here to welcome one of my colleagues, Dr. Krupa Nataraj, who is currently one of our third-year residents. Dr. Nataraj had attended St. George's University for medical school and received her Bachelor's of Science for the University of Maryland. And she's here to present today on physician suicide. And I think it's a very timely topic in a sense because upcoming in February is actually, resident and fellow Suicide Awareness Month, which we're also trying to highlight in a sense with our resident leadership committee. So looking forward to this talk, and I hope everyone enjoys it. Dr. Krupa.
Good morning. Can everyone hear me? Okay. So yeah, I thought this was a really relevant topic. Initially, I was going to do something about just suicide, but I thought this was more relevant, seeing as a lot of us in this room are medical students, residents, and doctors. I can't hear. How about now? Better? Can you hear me? How about now? Can you hear me? Better? Yes? Can you hear me? How about now? No? Okay. Okay. So my topic is physician suicide because I felt like a lot of us in the room are medical students, residents, and doctors. And I wanted to talk about the stigma with accessing mental health services. And there was a lot of research on it. So first I'm going to define stigma for one of the articles that I found. It's conceptualized as a complex social process of labeling, othering, evaluation, and discrimination involving an interconnection of cognitive, emotional, and behavioral components. You can't hear. Is that better? Okay, perfect. No problem. Okay. So back to defining stigma. It's conceptualized as a complex social process of labeling, othering, devaluation, and discrimination involving an interconnection of cognitive, emotional, and behavioral components. So what is stigmatization? It occurs on multiple levels simultaneously. We have intrapersonal self-stigma, interpersonal relations with others, so stigma between colleagues and other people that we interact with. And then there's also structural, discriminatory or exclusionary policies, laws, and systems that affect us. So I wanted to go over some scary facts that I found, and I thought they were kind of surprising. So the most common factor The most common risk factor for suicide is having untreated or inadequately managed mental health conditions. An estimated 300 to 400 physicians die by suicide in the US every year. And that is by far the highest suicide rate of any profession. Physicians who took their lives were less likely to be receiving mental health treatment compared to non-physicians who took their lives, even though depression was found to be a significant risk factor at approximately the same rate in both groups. So physicians are getting help less often. Suicide rate among male physicians is 1.41 times higher than the general male population. And among female physicians, the relative risk is even more pronounced. It's 2.27 times greater than the general female population. Suicide is also the second leading cause of death in the 24 to 34 age range. Accidents are first, and that I thought was significant because a lot of residents fall in that age group. 28% of residents experience a major depressive episode during training versus 7 to 8% of similarly aged individuals in the US general population. Among physicians, risk of suicide increases when mental health conditions go unaddressed and self-medication occurs as a way to address anxiety, insomnia, or other distressing symptoms. Although self-medicating mainly with prescription medications may reduce some symptoms, the underlying health problem is not effectively treated, which can lead to tragic outcomes, and I have a few examples that I'll talk about later. In one study, 23% of interns had suicidal thoughts. However, among those interns who completed 4 sessions of web-based CBT, suicidal ideation decreased by nearly 50%. A lot of drivers of burnout they found include workload, work inefficiency, lack of autonomy at work, the meaning that people find in their work, and work-home conflict. So physicians have we commit a lot of our time to work, and so that leaves less time for our personal lives. So there's a lot of conflict there. And unaddressed mental health conditions in the long run are more likely to have a negative impact on a physician's professional reputation and practice than actually reaching out for help. So the main takeaway message that I got from this is let's get help early, because yes, people might find out, but it'll have less impact on your profession. Dr. Ben Schaefer, he was voted most likely to succeed in high school. He was also voted most school spirit in junior high. He cracked jokes up and down the hallways of the hospital, and his coworkers and patients loved him. He was a top DC sports surgeon at the time of his death, and they also called him Dr. Smiles because he was always laughing. And nobody had any idea that he was suffering at all. Why is he dead now by suicide? What you didn't see from his smile was his chronic lifelong anxiety, plus he had marital and work distress, which I think we all have. That's not unique to Dr. Schaefer. Reimbursement was also going down, and that puts stress on you when you're in private practice as an orthopedic surgeon. So he had pressure from his coworkers as well. Being a physician is a very demanding career choice, and we've given up a lot in our personal lives. Who here has stress from relationships, finances, children, friends, work? On top of that, he just had back surgery. He was dragging his foot because he was expected to have a complete recovery faster than expected. But then having chronic anxiety on top of that was very crippling for him. His psychiatrist, who had been treating him for a long time, also retired and passed him on to a new doctor, changed his medication regimen, took him off of benzos. He had worsening insomnia and anxiety. So he had marital work distress, status post back surgery, chronic anxiety. He was on a new prescription for 8 days, Prozac and Seroquel, which actually worsened his anxiety and caused paranoia. He was also told by the new psychiatrist that he would likely be on medications for the rest of his life, which he'd never heard before. A few days before he committed suicide, he admitted that he had suicidal ideations for the first time. And a day before, he told his partners he needed to take the rest of the week off, and they were very agreeable, but he didn't tell them why. And he knew at that point that he needed inpatient care. But he was scared to be hospitalized because of the stigma and reputation that would be associated with it. He didn't want his patients or his colleagues to know that he needed inpatient mental health treatment. So rather than seeking inpatient treatment, he went home and hung himself on a bookshelf on May 20th, 2015. He was scared everyone in town would find out that he had mental health problems. So that was one case that I thought was, very shocking and representative of what happens in our field. Another case, Dr. Ortiz, he refused to do surgeries when more conservative therapies were more effective. But again, in private practice, he was bullied to perform more surgeries. And as a punishment for kind of rebelling, he lost 30% of his income. He also had his career threatened, and his peers told him to just go with the flow. He called his mother the night before. He left a letter naming people and what he witnessed in his career that he didn't like. 2 a.m., he checked in his patients and left a note thanking his staff because he really enjoyed working with his staff. And then on February 8th, 2017, he shot himself in the heart. And I feel like he's an example of physician burnout. So what is physician burnout? Burnout is a long-term stress reaction marked by emotional exhaustion, depersonalization, and a lack of sense of personal accomplishment. So there was a study where they had more than 15,000 physicians from 29 specialties who responded to a recent survey about burnout and depression. The survey asked about the prevalence of burnout factors and how they affected physicians' lives. They found that 42% of respondents were burned out or considered themselves burned out. 15% admitted to experiencing either clinical or colloquial forms of depression. More than 50% of respondents chose too many bureaucratic tasks as the leading cause of burnout. Other reasons that they also found reported during this study: too many hours, lack of respect, increased computerization of practices, and insufficient compensation. Another survey was done of just female physicians on a closed Facebook group. The Facebook group was just a group of female physicians. It asked about mental health history and treatment, perceptions of stigma, opinions about state licensing questions on mental health, and personal experiences with reporting. They found that 2,106 women responded, representing all 50 states in the U.S. Most of them were aged 30 to 59, and almost 50% of the women believed that they had met criteria for mental illness, but had not sought treatment. Key reasons for avoiding care: the belief that they could manage it independently, not having enough time, fear of having to report their mental illness or treatment to a medical licensing board, belief that their diagnosis was embarrassing or shameful, and only 6% of physicians with a formal diagnosis or treatment of mental illness had actually disclosed to their state boards. They drew some conclusions. Women physicians report substantial and persistent fear regarding stigma, which inhibits both treatment as well as disclosure. Licensing questions, particularly those about a diagnosis or treatment rather than functional impairment, may continue to contribute to treatment reluctance. So questions about the fact that you've had depression in the past, but instead not asking about, is that affecting you currently? So I wanted to read a passage from the New England Journal of Medicine, and I'm going to read it word for word from the article. If my colleagues knew that I was bipolar, I fear that I would never again be taken seriously, that I would be viewed as the impaired physician who, at a display of passion or emotion, would be seen as having an episode. My hard-earned credibility would be gone. My right to express even normal anger or irritability, happiness, or my effervescent sense of humor would be suspected as pathological. I would lose the right to have just a bad day. If I had lost a breast to cancer or had Parkinson's disease, I would have had the concern and sympathy of my community. But this illness is perhaps harder to bear because it is yoked with shame and secrecy. I am not missing a body part, nor do I have a resting tremor. Yet I still struggle with a chronic and debilitating illness associated with a high morbidity and mortality rate. If I continue to live pretending to be other than who and what I am, how can I hope the world will evade and become a better place? It is time to give mental illness a name, a face, a story. Only in doing so will the stigma of this disease lose its power. This passage was recently published in the Journal of American Medical Association by a physician who's lived with and been treated for manic depression for 30 years. I feel like her words convey the power of stigma experienced by physicians with mental health, mental illness, and her struggle with disclosure and secrecy. She proposes that by making mental illness personal, by connecting the illness with someone we know, will the power of stigma among members of the medical profession be weakened? And that takes me to the culture of medicine and medical training. Sometimes we work exhausted or perhaps more ill than our patients. Covertly, we get the message. We are to rise above any human frailty. It isn't a conscious process, it's rather what we have become. Resilience isn't taught, but it's expected, and we come to expect it in ourselves and each other. Therefore, to admit a problem is to admit that we are somehow less than and not equal to our peers. We feel shame, we fear being judged and stigmatized, so we tend to suffer in silence and carry on in a profession that prides itself on stoicism and bravado. How many of you have come to work sick? Or after staying up all night with a sick family member? Does anyone ever say, Dr. So-and-so wasn't tough enough to fight off her cancer? But when a doctor dies by suicide, some people might say, oh, Dr. So-and-so may not have been strong enough. We were worried she couldn't handle being a doctor, or he couldn't handle being a doctor. Another meta-analysis that I came across looked at data from 31 cross-sectional studies and 23 longitudinal studies, and they summarized the estimation of prevalence of depression or depressive symptoms among resident physicians was 28.8%. That's almost a third. The median absolute increase in depressive symptoms with the onset of residency training was 15.8%. More research findings. Researchers looked at studies of doctor suicide through PubMed and Medline during the past 10 years. And they found that although female doctors attempted suicide far less often than women in the general population, their completion rate exceeds that of the general population by 2.5 to 4 times. It also equals the completion rate of male doctors. Some of our most common diagnoses include mood disorders, alcoholism, and substance use. Findings also suggested that having knowledge and access to potentially lethal substances accounts for the higher rate of suicide completion. The same study looked at toxicology reports for physicians who had died by suicide, and they significantly found antipsychotics, benzos, barbiturates, and alcohol as significantly increased. What does that mean? Physician suicide victims do show a dramatically higher likelihood of having measurable levels of benzos and barbiturates. This is significant because of its infrequent use for therapeutic purposes and its known lethal potential. The equally dramatic increased likelihood of measurable antipsychotics was found to be unclear as to its significance. They also found the physician who commits suicide is far less likely to have had a recent death of a friend or family member or a recent crisis contribute to the suicide, but it's much more likely to have a job problem contribute. And of all medical specialties, psychiatry is in the top 5 in terms of suicide rates after anesthesiology, surgery, emergency medicine, and OB-GYN. Physician reluctance to seek treatment for mental health care may begin as early in training as college and medical school. What are some barriers to mental health care for psychiatrists? Most psychiatrists, they found in this study, 86.2% would be reluctant to disclose mental health illness to colleagues or professional organizations due to issues of confidentiality, stigma, career implications. And regarding career implications, I'm going to go on to talk about medical licensing boards. Most state medical boards require disclosure of mental health problems on all applications. Is this preventing us from seeking help because we have to report it? Is this increasing stigma? And there are special rules and programs that some states require if you do report a history of mental health illness and or treatment. And I thought this next fact was pretty shocking. Only a third of the states have licensing and renewal questions that either inquire only about current impairment from mental health conditions or did not ask about mental health conditions altogether. Is that a violation of the American Disabilities Act? Physician reluctance to seek mental health care is shaped by stigma of mental health in the medical community and fears of professional discrimination, including potential consequences of disclosing mental health diagnoses for obtaining a medical license. Possible repercussions of full disclosure of mental health conditions. Some doctors might be asked to appear before state board examiners. They may, in some situations, have to pay, depending on the state, pay for a board-appointed physician examination. So it's out of pocket, but the board requires it to get a license. You may have to provide testimony from your primary care doctor as to their fitness to practice, detailed medical records, and documentation of continued medical care. There also may be restrictions on the physician's practice sometimes based on past psychiatric care. So Dr. Adam Hill is an associate program director who discloses his experience with stigma. And there is a video.
To me, the greatest hypocrisy of all of this is that we take an oath to heal. To me, the greatest hypocrisy of all of this is that we take an oath to heal other people that are suffering and take care of those that are affirmed, and that when it is within our own walls, then we turn a blind eye. And to me, that's a travesty. Just statistically alone, there's probably several hundred thousands of physicians working in this country with a history of mental health conditions. So it's striking to me that so many people feel isolated because there's so many of us out there. I had a family history of depression, and myself had a predisposition for that. And so early on, even in my career, that began to surface. There was a time in my life where everything reached a critical mass. You know, I really had to take a pause and take some time away to take care of myself and figure out that I need a plan in place to be able to take care of myself well so I can continue to do this work. And so that's what really led me to recovery. I mean, I honestly look at it now, having a history of depression as being the greatest gift and blessing in my life. It has allowed me to connect to patients on different levels, and really that's the majority of the work I do is about building trust and relationships and supporting. A lot of it just looks like talking, but it's getting to know them, getting to know what's meaningful, valuable to their life, and then being able to, help. But you never can do that unless you know somebody and know what's important to them. And so I think sharing some of our own stories and sharing our experiences just helps to build that. To me, that's what one of the main meanings of purpose of life is, to share our experiences, to share our stories, to connect to other people and let us know that we're not alone. What I hope speaking up will help to change, that other people will feel comfortable enough to be able to share their own stories. And so the truth of the matter is there's an incredible liberation with living authentically.
Okay, so Dr. Adam Hill had a history of depression. He had suicidal ideation, and he was also an alcoholic in recovery. There was a time when he sat in the woods in a park with no plan to come back, and he contemplated suicide. He felt abused, neglected, overworked, and underappreciated. So I feel we need to break down the barriers we've erected between our colleagues who are standing on the edge of a cliff and treatment and recovery. Empathy, unity, and understanding can help us shift that cultural framework towards acceptance and support. Mentally healthy physicians are safe, productive, effective physicians. What are some lessons that we can take from all of this research? Self-care is really important. We need to create a plan to enable us to cope with rigorous and stressful work. Some things to consider: counseling, meditation, mindfulness, exercise, deep breathing, support groups, and extracurricular activities. What interests you? And I also found that stereotyping is also a large component that we can avoid. Everyone has their own story. Every alcoholic is not a homeless person living under a bridge. Dr. Adam Hill, who is an associate program director, was an alcoholic in the past. And there's a lot of stigma out there. It's really ironic that mental health conditions are so stigmatized in the medical profession. Physicians long fought to categorize them as medical diagnoses. Why do medical institutions tolerate the fact that more than half their personnel have signs and symptoms of burnout? And when medical conditions come too close to us, we tend to look away, or to look with pity, exclusion, or shame instead of reaching out. Vulnerability. We're all vulnerable. Social media often portrays people as having perfect lives. Setbacks and failures are a normal part of life. We all have them. But physicians fear that showing vulnerability will lead to professional repercussions, judgment, and reduced opportunities. Professionalism and patient safety. Physicians who are successfully engaged in a treatment program are the safest to be treating other patients. And it's important to build a support network. I feel that we all need support no matter what profession you're in, but especially physicians, because it's a very stressful career. What progress have we made? The AMA House of Delegates took actions aimed at destigmatizing and studying mental illness among physicians and medical students during the 2017 AMA annual meeting in Chicago. The House of Delegates authors argue that physicians may be less likely to seek treatment for mental health impairment for fear of sanctions or repercussions. They cited extensive research that suggests boards approach medical illness with more scrutiny. That's supposed to say mental illness with more scrutiny than physical illness. So they did acknowledge that boards have different guidelines for mental illness than physical illness. New AMA policy encourages state medical boards to recognize that the presence of a mental health condition does not necessarily equate with an impaired ability to practice medicine today. There was a study about web-based CBT intervention because they found that suicidal ideation increases more than fourfold during the first 3 months of intern year for residency. This program that they tested was delivered prior to the start of internship to assess the prevention of suicidal ideation in medical interns. So the study started, they had a baseline survey, they randomized the participants and had CBT for 4 weeks before the July start date, and they also had a group that had just emails and did not have CBT. Interns started in July. They reviewed and had 1 CBT session in August, and the control group had just an email. In September, they had a 3-month survey. November, they had 1 more CBT, and the control group had an email. In December, there was a 6-month survey. February, another CBT versus control had email. 9-month survey, and 1 more CBT session in May versus the control had an email. And then they had a 12-month survey at the end of intern year. And they found that the number of interns endorsing suicidal ideation during intern year was significantly decreased with the CBT study that was delivered to them. 12% of interns assigned to the CBT group endorsed suicidal ideation compared to 21% of interns assigned to the control. Interns assigned to the CBT group were less likely to endorse suicidal ideation during intern year, with a p-value of 0.03 compared to those assigned with ACG. And free, easily accessible, brief CBT program is associated with reduced likelihood of suicidal ideation among medical interns. That was a conclusion from that study. So from there, we kind of go to, okay, we have all this data, but what can we do about it? We can educate and raise awareness about mental illness among physicians. We can implement assessment and identification of mental health concerns for physicians. But how do we do that while still respecting the privacy? Do we want our bosses and our program directors to really know what we're struggling with? Is that going to cause any bias with our jobs and decisions? So that's something that we may not have a solution for yet. But providing safe and confidential support to help physicians in need is very important. And I have marathon. Any questions? Dr. Sandra? I did have some studies, but I didn't really go into those because Dr. Zaza and I wanted to kind of focus on physicians for this one. We thought it was more relevant, but I did come across some studies. I don't recall the numbers. Mm-hmm. Yeah, that I'm not sure. Mhm. 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 And I think it's good that peers are starting to come out about it so that it kind of normalizes that, it's it's okay. A lot of other doctors are dealing with the same thing. Mm, mm. I think it was individual, but I can confirm that. Mhm. 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 I would have to check on that. Yeah. And another concern in a smaller city program like us, we're psychiatry residents. A lot of the professionals in the area we've either worked with, had lectures from, um, so we know them. Is that preventing us from reaching out to them for help? Mhm. 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 Yeah. I'm not sure because those were two different studies, so they didn't really connect that idea. But that would be something really interesting to look into. Mhm. Mhm. Right. Alcohol. From the study, I did collect that a lot of the concern was people with like drug abuse problems and things like that being in practice. Mhm. And I just wanted to conclude by thanking Dr. Isaja, my mentor, for his support and feedback. No problem.